I'd just like to say welcome to all of our participants today. I'm delighted you could be here for the RM Partners webinar series, and today we're going to talk a bit about radiotherapy. So I'll just introduce Nate Hill, who's working with me to do the chairing, and Nate works for RM Partners and they're sponsoring this series of webinars. And I'd like to introduce Sophie Alexander, who's going to be our first speaker. And Sophie, could you just tell the listeners where you work and the title of your topic, etc.? That would be fabulous. Just I'll mute myself and then you let me know when you need me to come back in. Thank you, everyone. If people come in and out or your Wi-Fi drops off, sometimes your sound comes back on. So if you could just mute yourself, otherwise Sophie will get a feedback mechanism. That would be fabulous. And I will put my picture off for a minute. Okay, thanks, Sophie. Over to you.
Thank you very much for inviting me to talk today. My name is Sophie Alexander and I'm a therapeutic radiographer working at the Royal Marsden Hospital, currently based in our Sutton branch. I thought I'd start with a little introduction to me. So I started working as a clinical radiographer at the Royal Marsden back in 2008. I was interested in research, so I completed a part-time MSc, which I completed in 2016. I then moved into a urology specialist role in the same year. And then it was only in March 2022 that I assumed the role of radiotherapy research superintendent. This is a post that is funded by a Cancer Research UK grant, and these are the grant holders, Dr. Alison Tree and Professor Uwe Olfger. Then a year later, so March 2021, I enrolled to do my PhD part-time, and Dr. Helen McNair is the third supervisor. And my project title for my PhD is Stratifying Patients for Optimal Benefit from Novel Adaptive Radiotherapy. So bearing this in mind, today I wanted to talk to you about adaptive radiotherapy, introducing you to the concept and then discussing a little bit about what I'm doing in my PhD project. So firstly, and I know you all know this, patients are not clones, they are people, they're individuals. They are different sizes, shapes, ages, ethnicities. Also, we have to remember that their medical history is different, as is their daily activity, their diet, their mental health, and their wants and expectations of radiotherapy and other treatments. But variations aren't only external, they're also internal. The same anatomy looks and moves differently from one patient to the next. And one way we have to manage this is with adaptive radiotherapy. So firstly, I thought I'd look at what is adaptive radiotherapy, and I appreciate it's a mixed audience today, so I thought I'd consolidate your understanding in a very simple way. So typically radiotherapy starts with a planning CT scan, or some might refer to it as a CAT scan, and this takes place approximately 2 weeks before radiotherapy treatment begins. And I should just point out, this is my cat Nina, who's modelling today. So on this scan, the target anatomy is delineated, so it's drawn around, and then a safety margin is added to that. And this safety margin allows for daily uncertainties in not only the target position, but also the surrounding normal tissue. And on this image, the radiotherapy plan is created. And with a non-adaptive approach, what we really rely on is that the anatomy lines up every day of radiotherapy as per the planning CT scan. Unfortunately, in reality, that's not always the case. The anatomy is in different position, and as a result, the plan that was created is reduced in accuracy. Now, of course, radiographers utilise immobilisation and patient preparation to reduce this motion, but I hope you get the gist from the picture. With adaptive radiotherapy, this allows us to make alterations to the plan on a daily basis to compensate for changes in tumour or the normal tissue surrounding. So now, if we have a change in the position, the new position can be updated, and what I wanted to do was focus on two methods of delivering adaptive radiotherapy that we have implemented at the Royal Marsden Hospital. The first method is a plan of the day approach. a plan in the day approach. And we use this to deliver radiotherapy for cervical cancer and for bladder cancer. And this treatment is delivered on a standard linear accelerator. And the other type of adaptive radiotherapy we have is real-time adaptation. And this is used to treat a number of different treatment sites at the Royal Marsden. And we deliver this using an MR Linac, which we have at our site in Sutton. So firstly, let's look at the need for and the benefit of a plan of the day adaptive approach in cervical cancer. So the primary target volume for patients with cervical cancer includes the uterus, cervix and upper vagina, and it's drawn in green in this picture. For each patient, the included anatomy is the same, but I've just looked at 4 different patients here treated at the Trust, and I've roughly contoured their primary target in green. And you can see for these 4 patients, although we're treating the same anatomy, the anatomy looks very different. But why does anatomy look very different, and why does it move differently? So for cervical cancer, bladder volume plays a significant impact on uterus position because the uterus sits directly on top of the bladder. As the bladder fills and empties, the uterus is also moved. But uterus size varies with age and number of pregnancies, decreasing in length after the age of 40. The image on the left here is from a 35-year-old woman, and on the right from a 70-year-old woman. Anatomy may also look different due to natural variations, an anteverted or a retroverted uterus, for example. We know that rectal filling plays a significant impact on cervix position and motion. These images are from the same patient, but you can see the image on the right, the rectum is much fuller than it was previously. And bowel habits can be affected by diet, by anxiety and depression, by the patient's activity levels, medication, and also as treatment goes through, bowel toxicity is very common. The stage at which the patient presents also plays an impact, with higher stage disease maybe causing a buildup of fluid in the uterus, as seen here. And as patients go through radiotherapy treatment, significant tumour regression is seen. These images are taken from week 1 and week 5 radiotherapy treatment. So without an adaptive approach, how we manage this motion is by adding a large margin around the primary target volume to account for this motion. But a consequence of adding this large margin is that more normal tissue is included in the radiotherapy field. And surrounding the primary target are very important organs, including the bladder, the rectum, and the bowel. So this could potentially cause the more normal tissue we include, the higher toxicity is expected. So in April, we introduced adaptive radiotherapy for cervical cancer. This approach is to acquire 3 radiotherapy planning scans rather than the standard one. So the 3 scans that we take is a full bladder planning CT scan, seen on the left there. We take an empty bladder planning CT scan, and then we acquire a mid-bladder MRI scan. And then from this, we can create a library of plans, and we create a library of 4 plans. So this means that rather than just having one option for radiotherapy on a daily basis, we now have 4 options. And this allows us to pick the plan that best fits the patient's anatomy on the day. So to show you a clinical example, this is our first plan of the day cervix patient. And these are images that are required immediately before radiotherapy delivery on sequential days. And I've just again drawn the primary target quite roughly there in green, and you can see the variation in shape and position of the target across those 4 days. Now with our standard practice, the images 2 to 4, they wouldn't have been adequate for delivery of treatment, so we would have to have got the patient off the couch, got them to fill their bladder further so that we could try and better replicate the planning option. But now that we have 4 plans to choose from, we had options to deliver accurate radiotherapy for each of these days. So what is the benefit to the patient? Well, it avoids realigning of the patient. We don't have to get the patient on and off the couch as much as we previously did. And the result of this is reduced stress and reduced time for the patient. Plan of the day approach has also been shown to improve target coverage and to reduce dose to normal tissue, including the bowel and the bladder. And this has potential to improve symptoms and quality of life following radiotherapy. I've included a couple of references there. It's not been easy to implement this. It requires really a significant multidisciplinary team approach, but really we think the benefits show that is required. So now I'll move on and look at the MR-Linac. So the MR-Linac couples a 1.5 Tesla MRI scanner with a linear accelerator, and it offers advanced and enhanced soft tissue visualization and enables adaptation of the patient's anatomy at each fraction. So here I present the improved image quality for a pancreas tumour. An abdomen is notoriously difficult area to visualize. So here we have the patient's planning CT scan, and you can see the target has been outlined and it is quite easily defined. This is a radiotherapy CBCT scans. These are the standard images that are required immediately before radiotherapy delivery. And you can see that it's not particularly clear. You can just make out a few blobs, which you can assume are a target, but it is quite difficult. And then this is a scan acquired on our MR-Linac, and you can see the definition of the target again is much easier and the image is much clearer. And with this improved visualization, we now have more confidence to increase the dose that we deliver to these patients, and we hope this will lead to improved patient outcomes. So let's look at real-time adaptation for prostate cancer. The target includes the prostate and a portion of the seminal vesicles plus a safety margin. I've just put it in that small diagram at the bottom. But as before, there are many variations in patients' anatomy. So again, this is 4 patients all treated on the MR-Linac, and this is their different prostate volumes. But don't just look at the prostate volume, which is contoured in red, and the seminal vesicles in green. Also look at the variation in the surrounding anatomy, the rectum, the bladder, and the bowel. The prostate is shifted and deformed by changes in bladder and rectal filling. For example, you'll see for this patient in just 15 minutes, there's a significant change in the rectal volume and the bladder filling. To moderate this, patients are given bladder and bowel preparation advice, but unfortunately it's not an exact science and variations still appear. Patient position and comfort is important, as discomfort promotes fidgeting and motion. And during radiotherapy, some recent work that we've done has shown significant prostate swelling during the radiotherapy treatment, especially for those patients having fewer fractions. The MR-Linac offers a solution to tackle prostate deformation. This example is a little crude. Again, apologies for my rough diagrams, but it just shows how the change in prostate volume during radiotherapy can be accounted for by recontouring on a daily basis, as can the change in rectal volume. So this is a patient on different days. And once we've re-outlined the targets, the plan can then be updated to give you an optimal plan for that day. Now, we're very fortunate at the Royal Marsden to have an MR-Linac, but it is a very limited resource, and there are only 2 NHS MR-Linacs in the UK and approximately 100 globally. But we have to remember that the radiotherapy department on a daily basis treats around 300 patients, and the MR-Linac only has capacity for 8 to 9 patients, depending on complexity. And some sites undoubtedly benefit from daily MR-Linac treatments, such as pancreas, which I showed you. But my colleague, Dr. Alex Dunlop, presented that for prostate cancer, many patients don't significantly benefit from daily adaptation. But there are some who have marked deformation and motion of the prostate that really do benefit from daily adaptation on the MR-Linac. The difficulty is that, unfortunately, we can't currently predict who these patients are up front. And as a result, from the 50 or so prostate cancer patients who consent to radiotherapy each month at the Royal Marsden in Sutton, we end up with some of those patients on the MR-Linac who are benefiting from daily adaptation, but we also end up with some patients on the MR-Linac who really aren't benefiting. And then there's those patients who would have benefited that aren't benefiting from this treatment and are having a non-adaptive approach on our standard Linac. So I hope that my PhD project will go some way to helping us predict which patients will benefit most from novel adaptive radiotherapy. My hypothesis is that demographic data and information taken from patients' diagnostic imaging can be used to predict if a patient's anatomy will undergo significant motion and/or deformation during their radiotherapy course. And if it does, they would likely benefit from adaptive radiotherapy. But if it doesn't, they are unlikely to benefit and would do well with standard radiotherapy, which is more widely available and is quicker to deliver. So, as discussed, rectal and bowel changes influence prostate motion and deformation. So in line with this, I have carried out a scoping literature review to investigate common lower GI affecting factors which haven't previously been investigated with relation to motion during radiotherapy. And I identified 4 key affecting factors, from which 6 sub-factors with predicted high prevalence in a prostate cancer population were established. And these were anxiety, depression, diabetes, obesity, physical inactivity, and pelvic floor disorders. So we now plan to prospectively capture this data from patients undergoing prostate cancer radiotherapy and examine for links between these and motion and deformation during radiotherapy and dose delivered during radiotherapy. And the literature and experts' discussions also identified suitable assessment tools which we can use in a very busy clinic to capture this data across our patient group. I hope that the findings for this from this work will go some way to helping us predict which patients really require an adaptive approach, and in doing so optimise the use of this novel adaptive machine, the MR-Linac. Learning more about our patients also opens opportunity to better personalise radiotherapy prehabilitation and preparation, and maybe you'll have me back to share my results in a year or so. So to summarise, we have to remember that patients are people and they're individuals. The imaging that we acquire during radiotherapy enables us to appreciate these differences from one patient to the next. Current technology allows us to adapt to patient variations, and there's always further work ongoing to improve this. Improved patient comfort supports the delivery of advanced radiotherapy, but we must remember that resources are limited and we need to develop strategies to identify who will benefit most. So I'll finish there. As already said, that I was my post is sponsored by Cancer Research UK, which is specifically looking at adaptive projects, and I'm happy to take any questions.
Thank you, Sophie. That was really interesting. I'm supervising a student at the moment who's doing some MSc work around cervical cancer on this very issue, actually. So it's quite interesting to see your take on it as well. So I've been meeting her project this morning. So I just wondered, while we're thinking if the audience have any questions, is it quite costly then to do this in terms of standard treatment? And is the cost, is that balanced out by the benefits then of treating the area? Have you done any work looking at the financial?
Not me personally, but there is ongoing work. Obviously the MR, things like, let's talk about plan of the day first. Obviously that's delivered in a standard linear accelerator, and we've in the audit that we just completed, we're delivering it in the same time as we would a single plan approach. So with regards to radiotherapy delivery, there's no additional costs.
So you're doing a plan at the beginning of the planning process. You do 4 plans over consecutive days.
So that's where the additional time and resources is required, is all up front. So that falls to our poor physics colleagues, really. Because what we found is it doesn't take 4 times doesn't take 4 times the time. It takes about double the time to, because we've got quite clever and sophisticated radiotherapy planning systems. So once you generate one plan, you can kind of take adaptations of that, which makes the process a bit quicker. So yes, for the plan of the day approach, it is more time costly up front, but it's not 4 times, it's about double. With regards to the MR-Linac, that is much more resource intensive. You know, we require a multidisciplinary team to deliver the radiotherapy. So with standard radiotherapy, it is 2 radiographers who would deliver the treatment. With an MR-Linac approach, depending on what we're treating, it will be 2 radiographers and maybe a physicist and a clinician. So you're looking at a lot. The resources are significant, and that's why it's important that we do this work to try and determine who is going to benefit most, because certainly if somebody is going to get a significant benefit with regards to reduced toxicity, there's potentially an overall saving there. But if we're not getting those benefits, then the saving is difficult. There's also, if we don't just think about toxicity, with pancreas, for example, we're just about to start that. Because we've now got the confidence to see the target, we're going to reduce down from 15 fractions of treatment, so 15 days. We now have the confidence to bring that down to 5 fractions, which we wouldn't have the confidence to do with our standard imaging. So there is benefits to be made.
Yeah, and also that's good for the patient in terms of quality of life and travel and all of that as well, isn't it?
Definitely.
Yeah. And yeah, I can see the benefits of doing that in a research trial, that's for sure, really. So in terms of consenting patients, is that problematic, or do patients really get the differences and what they're signing up to? Because sometimes that's quite tricky, isn't it? I know.
With the plan of the day approaches, they've really been, or they're starting to be adapted as standard practice across the UK at least. I think bladder cancer adaptive approach really led the way, and that was supported by a large national trial, which allowed centres to bring in bladder cancer adaptive radiotherapy. Cervix cancer is a little bit more complicated because the target is so mobile. But with regards to consent, we have brought that in as our standard radiotherapy process. So although none of the evidence kind of directly shows a reduction in toxicity, we are treating less normal tissue. So the patients are still being consented for toxicity as they always were. But we hope that in time, actually, the toxicity and the risk of toxicity may reduce slightly because of using this plan of the day approach. With regards to the MR-Linac, all our patients at the moment are recruited into a trial. It's quite an open trial. It's delivering kind of standard of care treatment, but using MRI guided radiotherapy. So obviously their consent is slightly different in the fact they have to think about the MRI considerations, noise, heating. There's a lot of processes that go on with regards to that, but their radiotherapy delivery, it still uses a standard radiotherapy machine. It's just built in with the MRI. So again, the consent is fairly standard with regards to toxicities.
Thank you. Has anyone in the audience got any questions for Sophie? It was just me asking questions. If you've got any questions from anyone in the audience.
There's also some of my colleagues for cervical cancer that are looking into ultrasound as well, because we base our standard radiotherapy on cone beam CT, but also that gives additional dose. You know, good things about the MR-Linac, there is no additional radiation dose when we're acquiring these images. But ultrasound is also some kit that some of my colleagues are looking at to see if we can use ultrasound to kind of inform how the target is moving during treatment. Again, that's got no additional dose, so that's got benefits.
So doing ultrasound during the treatment?
Yeah, so at the moment we're just kind of doing it. At the moment we're doing it kind of up front to just get some more information on how the target looks and how the images will look compared to our standard radiotherapy image. But Yes, if we could use ultrasound to monitor position during delivery of radiotherapy, then you can potentially identify when there has been motion during treatment. Some sites are using it for things like prostate cancer as their standard of care at the moment, but it's not widespread.
Thank you. If anyone's got any questions, they want to pop them in the chat if they don't want to pop themselves on. I've got a comment saying it was really enlightening, so thank you. So I don't think there's any more questions. Are you able to stay, Sophie, or have you got to dash off?
No, I'll mute myself and I'll stay.
Okay, so I'll move on to the next talk now, and Sophie will be there. So if you think of any questions, we can come back at the end. So unfortunately, Naman, who was due to be with us, who's a therapeutic radiographer, is unable to join us today. So he's recorded his talk. Here we go.
Hello, my name is Naman Johansen. I'm a Macmillan Treatment Review radiographer working at Imperial College Healthcare NHS Trust in Charing Cross Hospital in radiotherapy. So I'm here to talk to you about the podcast Rad Chat that Joe McNamara is on the left of the logo, and I relaunched in December 2021. So just a bit about me, in case you don't know who I am. I was born and raised in India in 1993. I moved here in 1999, and I work as an advanced practice radiographer specialising in treatment review. So I also co-host Rad Chat, and on the bottom, just a few of the charities that I'm an ambassador for and work for. So Radiotherapy UK, Truckstock, and Move Charity, who also run the 5K Away initiative. So Rad Chat is the first therapeutic radiographer-led oncology podcast. Joe and I relaunched it in December 2021. So prior to that, I was part of a different podcast, but the person I set it up with didn't want to be part of it anymore. So Joe and I had been working together virtually for the past couple of years before that. And then I decided to ask her if she could come and co-host with me. She will obviously always stipulate that I asked her to come along because she has a very large contact book. Which is slightly true, but we're a good team. So she has an education background, so she's a senior lecturer in radiotherapy and has also been a clinical fellow for Macmillan Cancer Support as one of the first AHPs to do that role as well. So together, my clinical side and her education background, we work quite well together. So we started to split the podcast into 4 main themes. So living with and beyond cancer, education, workforce development, so EDI and leadership as well. Slightly biased with the Living With and Beyond Cancer series. They're probably my favourite ones, as we have guests who have been touched in some way, either themselves by having cancer treatment or a cancer diagnosis, or we had Steve Bland on, who was a bystander to cancer, and he's part of the You, Me and the Big C podcast, and his wife obviously died from cancer a few years ago. So that series in itself is just understanding real life experiences, and I think that's really important. I think in healthcare we don't necessarily get to see or listen to different patient experiences from this kind of element. It's usually when we're face to face with the patient, but yeah, through your ears and understanding and learning through kind of structured questions that we've asked them, or any points that the patients themselves want to raise, it's been really, really useful. The education workforce development, quite straightforward what that's about. Might be sort of maybe talk about prehabilitation, for example. So just educating, and the workforce doesn't necessarily mean therapeutic radiographers. We have a wide range of listeners from across the world now. So yeah, nursing background, other AHPs, medical professionals as well, and also non-medics who want to learn a bit more about oncology. Equality, diversity, inclusion is a theme where we talk about different kind of elements, so either LGBTQ+, racism or things like that, but actually we've tried to weave EDI aspects into all of the podcasts anyway. So this one is more specific on certain topics. And leadership is getting sort of leaders within their profession or their field, their area, linked to oncology in some way. For example, we had Linda, who used to be the Macmillan CEO. She came on to discuss her journey. I think one of my personal favourites was Dame Laura Lees, who's the Maggie's Centre CEO. So she came on just discussing how she got to where she is. So yeah, in all, really, I mean, I think the podcast itself is about living with and beyond cancer in some way, and we weave a little bit of leadership, EDI, and education and development into each episode. So yeah, this is the first year, obviously, of doing it. So next year we might do it slightly different. We haven't decided yet. So with regards to continual professional development, I think most people like this webinar. You'll be watching a webinar, you'll read something, you do a module or a course or something like that. So I think it was a novel way to consider podcasting as a way of continual professional development. I will have to say that Joe was great for this. It's something I always wanted to do. I had no idea how to go about it. So having her on board, and we both applied for accreditation with the Society of Radiographers for their CPD Now program. So just an example on the bottom is for each episode that we release, we'll have some CPD reflection points, usually 3 at the most. But I think for this one, we just did 1 or 2. So this was Stuart O'Callaghan. It was their episode just around LGBTQ plus, and also about Live Through This, the charity that they created. So just, it will come up on your Spotify, Apple Podcasts, whatever your normal podcast library is, or even just on our website. So you can read the resources, do the reflective questions, send them back to us via a Google form, and then we'll give you a certificate, which will mean some CPD points. So yeah, kind of learning on the go. I think the average commute is around 45 minutes. So normally we aim for episodes to be around that time. So it's something you can do even on the commute to work. So as I said, we relaunched in December 2021. So we're been up to a year of kind of working on this podcast together. So we were only in the UK in December last year. And as of today, as I've just checked and taken another screenshot of this lovely map that we get from our host network, we are in 74 countries worldwide, which is pretty incredible, I would say. And if you think that, I think in 2020, around 18.1 or 18 million new cases of cancer were found worldwide. I mean, if we're in 74 countries, even if we have 1 cancer patient from our episodes in that country, the impact that we can have over time is incredible. So our host network that we have, it distributes all of the episodes within sort of 5 seconds or so to 30 podcast libraries worldwide. So including, as I said, Spotify, Audible, Apple Music, and you can also just listen on our browser. So we have a link to our website through this host network, which just hosts the podcast episodes there as well. I think this is quite important as it improves the access to certain kind of developing countries where they may not have subscriptions to Apple Music or Spotify. So just listening on our website, they can just do so for free. I think free access to medical education is really vital. I suppose with a multitude of general public, patients, health and care professionals and students listening, because we're quite excited that we can continue to offer this free resource, and kind of avoiding any technical inequalities as well worldwide. So a little bit more nerdy, I suppose, if you're interested in some of the technical side of things, our host network kind of tells us what devices we're being listened on and what sort of platforms. So on the left, we're looking at kind of devices, so your mobile phone, desktop, etc. So the apps will include podcast libraries, such as Spotify or Apple Music. By having kind of our website, which allows for people to use it, you can see it's not the biggest chunk, but it's quite a large chunk. I mean, it's about 75% or more is mobile app. I think quite interesting is the use of smart watches, home units, TVs, etc., just showing how quickly technology is advancing, and also how easy it is to access a podcast. I mean, using your smartwatch to listen to something, you can't necessarily always watch something on there as well. So quite an interesting fact for our podcast. And on the right, looking at kind of what platforms we're listening to. So Apple and Android, they're quite common, obviously, products worldwide, but actually in developing countries, it's usually Android or using a desktop browser or a website. So I think there's a stat that in 2019 Digital's Insights survey, they found that 75% of healthcare professionals use their smartphone to listen to podcasts. But I think technically breaking it down, I think it's really important that we are able to give access to different countries. So I know of someone in a developing country who works in India that has listened to one of our episodes in an internet cafe just because they're able to. So yeah, hopefully not too nerdy and hasn't made you bored of listening to me, but I just think it's an invaluable insight as to how far technology can really go, and how quickly we can share medical information worldwide. something quite exciting, obviously within, we've not really been working for a year, but apart from just the episodes, we've been the official podcast for 2 conferences as well. So Oncology Professional Care, which was in May at the Excel this year, will be at the Excel again next year. And also UKIO, which is the radiography specific conference that was up in Liverpool in July. So yeah, I think it's amazing to have what we call the pod box there. So doing live podcasts, as you can see on the left with the microphone. So just grabbing guests and speakers and anyone really wanted to come and talk about the conference or oncology or what they've learned so far from any of either our episodes or just some of the sessions that they've seen. I think, again, the main driver really for Joe and I is that we just want to showcase patient stories to improve the radiotherapy service, and obviously being biased, but showing off the role of therapeutic radiographers to the world and kind of what we can really achieve and what we can do. So yeah, it's quite exciting for us, and we're doing the same again next year for both conferences. So just wanted to share some of the feedback that we've had. So obviously doing the CPD points, when people complete them, they can also give us feedback as to why they chose this, a certain episode on their kind of CPD journey, if you want, through the episodes to gain some experience and understand what's going on. So I suppose, patients sharing their experiences about inequalities they've experienced during cancer treatment is obviously quite hard to listen to. I think it'd be easy to try and defend situations that occur, sort of dismissing, what is important to them, but really using active listening through the podcast allows us to think about our practice and bias, especially any kind of systemic or institutional bias that occurs. We're obviously very lucky with some of the incredible charities that we're able to work with, and obviously feature them as well on episodes, either by having someone from the charity. So we had Jemima Reynolds from Trekstock Charity come on just to discuss her role, what their charity offers for young people who are living with and beyond cancer, but then also being able to signpost. So hearing this, that actually one of our episodes, they've now learned of a different charity, which is now helping their patients, and obviously will continue to help their patients in the future. It's obviously great for us and obviously for the charities, especially the smaller charities. So quite a fun few episodes. If anyone doesn't know who this is Lorraine Grover, a sex and intimacy expert. She came along to our pod box at Oncology Professional Care with her lovely suitcase full of goodies to talk about sex and intimacy with us. The feedback that we've had around our sex and intimacy episodes is obviously it's a topic that can be quite taboo. It's quite difficult to talk about. I think some more junior staff might feel less comfortable openly discussing certain things, but yeah, Joe and I both really enjoyed them, and obviously with Lorraine in the pod box was good fun, but it's just trying to break down those barriers and really help educate people on topics that we should be feeling quite confident to talk about. So I was very lucky to speak at Estro this year, just around radiation-induced skin reactions and the lack of diversity in skincare assessments. I think this feedback just around our skincare episode that we did, so just talking about skincare for radiotherapy-induced skin reactions, it was quite powerful. It shows that actually, even what I found through my research, we are just scratching the tip of the iceberg. I think the power that this one episode has to discuss skincare, not only in a radiotherapy setting, but this person as a health visitor in an inner city area, actually just under a small identification between skin tones, that's now going to help their practice and probably and hopefully their colleagues forever. So yeah, another great kind of insight into what we're able to achieve just with one episode. Very lucky to have Dr. Liz O'Riordan on as a guest at the start of last year. Obviously an incredible advocate for people living with and beyond cancer, breaking down barriers, kind of destroying cancer myths, especially around nutrition. She obviously had radiotherapy treatment and was very open on in the episode that when she was an oncologist, she used to just say, "Oh, it's just a bit of radiotherapy, you'll be fine." It wasn't really until she had treatment that she understood actually how difficult and challenging some of the side effects can be. So yeah, her sharing her invaluable experience with us, I think she was one of the first sort of blue tick guests, if you want, that we had on. So it's great for us to showcase how hard we've worked to get people like this on. but also just having her advice on keeping her arms warm during radiotherapy treatments. Now, I know I've been saying that to my patients ever since this episode as well. But even that one little point is now going to help hundreds of thousands of patients forever in quite a cold room, which is for radiotherapy. So I didn't want to talk too much because obviously what we've done is great. It's more about our guests and the people we've been able to kind of convince to come on and share their experiences. So I suppose just an acknowledgement to them, especially all the healthcare professionals as well, who come on, give up their time in the evenings with us to educate the workforce, talk about their leadership journey, their challenges, all these sorts of things. And hopefully for years to come, we can continue to do that and keep providing kind of good episodes and webinars and Instagram lives, etc., things like that to people who are listening. But yeah, thank you for listening to me. If you have any sort of questions or any technical thing, anything you really want, either give us a follow on social media, message us, or just drop me an email. There's a QR code on the screen to our website for Rad Chat. So yeah, if you think there's anyone you know, or if you think you've got a topic area that might be great as an episode, or even an Instagram live to discuss, let us know. Joe and I are involved in quite a lot of research coming out from the podcast as well. Been invited to speak at a few more conferences and things like that. I should also mention here, we did win the Radiographer regional team of the year and also the UK team of the year for the podcast, which was amazing. So we found out last week. And then the day afterwards, we also found out that we won the European Federation of Radiological Sciences Patient-Centered Care Award, which is even more incredible because that's for the whole of Europe. And some of the projects that we were up against they had a lot more funding than we've had, let's put it that way. And they do that either as their part of their full-time job, whereas Joe and I do this on top of our full-time jobs. So it's quite amazing for us to win that national recognition. So yeah, hopefully I've inspired you to listen to us a bit. But yeah, thank you very much for your time. Hope the rest of your day goes well.
So thank you everyone, and Naman does apologise for not being able to be here today, but hopefully you got some information from that talk, and will be inspired to go and to listen to some of the Rad Chat. They're really amazing. They partnered with UConn to do some work as well, so we've got to know them quite well through that. Has anyone got any questions? I know Sophie is still on the call. Or anyone got anything that they want to clarify or raise, or any ideas, any topics that we could feedback that you'd like to see on Rad Chat? Be great for the society to get new pictures of skin toxicities to help the wider community. Sophie, do you know anything about that?
I know that Naaman is part of a Society of Radiographer group, and they're doing a whole project on skin care for across different ethnic diversities and skin tones. So I think there will be more guidance out. I think the project has only began in the last couple of months, so I don't think it's imminent, but there's definitely a team that have been put together to work on that.
Yeah, I was going to say, I think I saw something, but it only started about a month ago, didn't it? That they're actually getting a piece of project work to look at the different ethnic skin tones as well, because it's recognised that what we have in the current literature really isn't sufficient. So I suspect it'll be a fair while before we get it, but at least that's going on. So I'll feed that back as well, Sonia. So thank you.
Hi, just to say to everyone that obviously skincare is such a big issue, just to remind everyone that there's been the release of all the prosthetics for breast cancer, which Sarah did at the Royal Marsden. And obviously it's a long time coming because generally they were for white people. So we've got more ethnic diversity prostheses that fit in with the skincare stuff, because all the skincare pictures that we currently have for, desquamation are all very much to do with generally people of a certain skin color, and it would be nice for the society to pull, pictures that maybe people across the sort of patch could have, and that could be collaborated. But yeah, great about the podcast stuff, but thank you.
No, thank you for that comment, and I'll feed that back to Naam as well for you. Unless you wanted to email him yourself, you can do that too if you want to.
If you could put the email in the chat, that would be great, because I can
Yeah.
email him across. That would be great.
I think
Thank
his
you.
email was on the last slide. I'd just like to say thank you to Sophia for joining us today, and well, thank you to Naren, who in his absence, for sharing us that really interesting information. And if you all want to go off and explore the Rad Chat, that'd be fantastic. And please do listen to some of the episodes of the Living with and Beyond information. As he said, there's some really fascinating podcasts. They're quite nice and easy to listen to, really quite short. So if you think of any other topics you'd like us to cover, then please drop us a line as well. You can pop in the chat. And thank you all. I'll let you all leave when you're ready. Hopefully you can see the certificate as well. Thanks very much.
Thank you, Kay.
All right, nice to meet you, Sophie.